Very warm greetings to all. We have gathered here for Tanava's Stethoscopy Ceremony 2021, Rene Laennec Commemorative Oration, and Global Veterinary Cardiology Webinar. On behalf of the organizing committee, I wholeheartedly welcome a respected and beloved Director of Clinics, come Organizing Secretary, Dr. S. Balasubramanian, who has been motivating, supporting, and guiding us all through the program. I welcome you, sir. I feel delighted to welcome the speaker of the day, Dr. Brian Scanson, interventional cardiologist, Associate Professor of Cardiology, Service Head, Cardiology and Cardiac Surgery, College of Veterinary Medicine and Biomedical Sciences, Colorado State University, USA, for this program. I welcome you, sir. I welcome the deans and the faculties of all the constituent colleges of Tanuvas and other universities. I welcome Mr. Karnanidhi, Vice President, and Dr. Santosh Shinde of Alembic for this program. I welcome Dr. Arun Prasad, Professor and Head in charge of Department of Clinics and RVO, Dr. Selvaraj, Professor, Dr. K. Jayaraja, Professor, Dr. Balaganga Telayar, Dr. Arnaman, and Dr. Thirunaukathu for this program. I welcome all the students and the practitioners all over the world for this webinar. Welcome one and all. Thank you. Now may I request Dr. K. Jayaraja, Professor, Department of Veterinary Clinical Medicine, to introduce the speaker.
Good evening, one and all. So I'm very glad to introduce Dr. Brian Scanson. Dr. Brian Scanson is originally from Snohomish, Washington. He got bachelor's degree in oceanology and zoology from the University of Washington in 2000. He attended vet school at Michigan State University and concurrently pursued his master's in molecular virology in the year 2004. He went on to complete an internship in small animal medicine and surgery at Ohio State University and also his residency in cardiology in 2008 from Ohio State University. In the year 2010, he completed a fellowship in the interventional radiology and endoscopy at the University of Pennsylvania and the Animal Medical Center, New York. He served as assistant professor of cardiology and interventional medicine during 2009 to 15 at Ohio State University and also a director of cardiac catheterization and interventional medicine laboratory at Ohio State University. From 2015 to present, he is associate professor of cardiology at Colorado State University and also service chief, cardiology and cardiac surgery, Colorado State University. He has published over 200 original journal articles, book chapters, proceedings, and scientific abstracts in the area of cardiology. He serves on the editorial board of the Journal of Veterinary Cardiology, and he is also a founding member of Veterinary Interventional Radiology and Interventional Endoscopy Society. He is a renowned speaker on various international forums in the area of congenital heart diseases, interventional cardiology, and cardiac imaging. His research interests include congenital heart diseases, advanced cardiac CT and imaging, minimally invasive therapeutics of heart and vasculature. He is one among the first 4 veterinarians to pursue a fellowship in the training of veterinary interventional radiology and also section editor for the first textbook on veterinary image-guided interventions. He founded the first interventional cardiology fellowship worldwide. Most of his publications are unique and first in animal. With this brief bio sketch, I'm very proud to introduce our invited speaker, Dr. Brian Scanson. Thank you.
Thank you, Dr. Jayaraja. May I request Dr. S. Balasubramanian, Organizing Secretary and Director of Clinics, Tanuvas, for the felicitation address.
Good morning, Professor Brian, and good evening to the participants of this global webinar. So just a few words about the background on this global webinar. This directorate has so far organized 9 global webinars, and in that series, today we have the 10th global webinar. And this is a special webinar wherein we had from morning the Rene Laennec commemorative function. That is, first we had a stethoscopy ceremony, and in that we had the virtual workshop for the students all over India for the first time. And in the afternoon we had the second event wherein we had the seminar on pet care, like the heart care in pets. So for pet parents, we had that event specially organized. And now the third event for today's function is Rene Laennec Commemorative Oration by the most respectable and well-known, renowned personality of cardiology, interventional cardiology in veterinary science, Professor Brian Scanson. So it is very appropriate to have him today to deliver the lecture on advances in cardiovascular patient care in small animal practice. So I'm sure that the participants will have a great insight into that and have all the informations, basic as well as advanced, for their day-to-day practice. So on behalf of the organizing committee, though I am the organizing secretary, on behalf of the organizing committee, I would like to appreciate the efforts taken by the entire committee in making this event a grand success. Thank you.
Thank you, sir. Over to Professor Brian Scanson for the lecture, please.
Brian Selvaraj, you can start now.
Great.
Yeah,
Thank you so much. Thank you for the kind invitation and for your very generous introduction and kind words. It is certainly my honor and pleasure to speak to you all today about advancements in the cardiovascular care in small animal practice. I'll start with a few slides related to the namesake for today's meeting and webinar, Rene Laennec. This individual was born on this date in 1781 in France. He studied at the School of Medicine of Paris, graduating at the age of 23 as a doctor of medicine. And he has a long history himself of suffering from pulmonary disease, both tuberculosis and asthma. During his day, the assessment of the heart and lungs was based on what was known as direct or immediate auscultation. This meant that the practitioner placed their own ear on the patient's chest to listen to the heart and the lungs. In his experience, direct auscultation was as uncomfortable for the doctor as it was for the patient, and it became impractical in some situations, such as the auscultation of women. This was particularly true one day when Dr. Laennec was evaluating a female patient with cardiac symptoms. He felt he was not obliged to directly auscultate her. And so he acquired a roll of paper, rolled it into a cylinder, applied one end to the patient's chest and the other to his own ear. And to his surprise and delight, he perceived the heartbeat in a much clearer manner than he had previously. This led to the discovery and the invention of the stethoscope. His final prototype was a cylinder of wood perforated in its center longitudinally. He is the one who first derived the term stethoscope from the Greek words stethos and skopion, meaning chest and to look at. He is also the physician who was first known to use the term auscultation, from the Latin auscultare, meaning to listen carefully. No doubt, this contribution of the stethoscope changed the face of medicine, particularly in the understanding of thoracic disease of the heart and lungs, and opened up a very wide new field of physical diagnosis based on auscultatory findings and the diagnosis of pathology of the heart and lungs. In the preface to his seminal text describing his work on auscultation, he does actually make a point related to veterinary medicine as well. And I quote, "I have hopes that the advantages of my method of diagnosis may be extended in some degree to veterinary medicine. In the dog and cat and probably all carnivorous animals, the sounds of respiration are as distinct as in man. Notwithstanding these difficulties, I have no doubt further experience will prove the utility of mediated auscultation in the disease of animals, especially if combined with percussion of the chest." And so, even in the late 1700s, a physician recognized that auscultation can be of benefit to veterinary medicine, and the use of the stethoscope in our field soon followed its adoption in human medicine as well. For a long time, veterinary cardiology remained a study of physiology, a better understanding of the heart and lungs in animals to appreciate physiology in the human. These various studies of physiology date back to the 1600s and earlier, with the work of Galen, with the work of Augustus Waller and the development of the electrocardiogram. Up until about the 1950s, most work studying the heart of dogs and cats, and even horses and cattle, related to physiology and less so to disease. In my country, the United States, two centers developed in the mid-20th century with a focus on comparative cardiology, with the intent to better understand diseases of the heart in domesticated animals, to be able to apply that understanding to cardiac disease in man. These were at the University of Pennsylvania with Dr. David Detweiler. The Heart Station at the University of Pennsylvania is largely considered one of the founding sites in the world for the study of veterinary cardiology. Along the same time, Ohio State University with C. Roger Smith and Robert Hamlin was established. And that center also performed many pioneering studies understanding the presence, the spectrum, and the diagnostic findings of animals with heart disease. This quote from Dr. Detweiler in 1983 summarizes the state of veterinary cardiology prior to the mid-1900s. The idea that veterinary cardiology would grow into a recognized subspecialty seemed incongruous when it was generally believed that heart disease is rare in animals, and when present, untreatable. Hopefully what you'll see over the next hour is this is no longer the case. We understand heart disease is quite common in the dog, the cat, also in the horse, the cow, and other species. Furthermore, we understand that appropriate diagnostic tools, as are applied in the human, can be applied to the study of cardiac disease in animals. And what you'll see as well is now interventional therapies allow us to treat these diseases effectively for many of our patients. So if we think about the spectrum of heart disease that exists in the small animal patient, focusing primarily on the dog and the cat, we recognize that disease of the heart can occur of the muscle itself in the form of cardiomyopathies or myocardial diseases, in diseases of the valves, be it infectious, degenerative, or congenitally malformed, in the presence of other congenital defects, such as septal defects or arterial duct patency, in the presence of pericardial disease in the sac surrounding the heart, in the development of cancer in patients that are of older age, and in the development of electrical diseases, arrhythmias, and the like. Speaking briefly about each of these, degenerative valve disease remains the most common heart disease that we see in the dog in the United States and in many parts of the world. This is a disease where, with aging, the valves become thick the chordae become lax, and this leads to the progression of mitral valve regurgitation. This mitral valve regurgitation, or a leakage across this left atrioventricular valve, leads to progressive dilation of the left heart, increases in left atrial pressure, pulmonary venous congestion, and eventually the development of congestive heart failure for many of these patients, which both shortens the quality and the duration of their life. This disease also frequently affects the tricuspid valve, although we don't recognize clinical tricuspid valve to be nearly the entity and the severity that we see in the mitral valve. Valve disease also occurs related to infection of these valves. There can be large vegetated growths when the valve becomes a site of infection. Fibrin deposition occurs around areas of valvular infection. These are typically found in larger breeds of dogs. In epidemiologic studies, male dogs are more commonly affected. Many times a source or predisposition can be found, either a skin laceration or an underlying congenital heart defect such as subaortic stenosis. But in a good number of cases of infective endocarditis, no clear predisposing cause is found. These patients can be difficult to manage because even if we are able to clear the active infection, we are still left with a valve that is diseased, damaged, often regurgitant or stenotic, and that by itself may cause profound complications for the patient. When we think about myocardial diseases, these are diseases not of the valves, but rather of the heart muscle itself. These are more common in larger breeds of dogs and quite common in the cat. These are often genetic or familial in origin, and the question in the setting of dilated cardiomyopathy is many times whether it is a primary familial disease or a secondary consequence of some underlying condition. We see arrhythmogenic right ventricular cardiomyopathy affecting primarily the right ventricle, with a predisposition in certain breeds such as the boxer and the bulldog. Rarely we can see atrial myopathies where the atrial muscle is damaged, leading to atrial standstill and rhythm disturbances. We frequently see secondary cardiomyopathies related to underlying conditions such as systemic hypertension, hyperthyroidism, particularly in the cat, pheochromocytoma, and other adrenaline-releasing tumors, etc. Hypertrophic cardiomyopathy remains the #1 heart disease in the cat, but is relatively rare in the dog. When we think about dilated cardiomyopathy, we use this term to describe a ventricle that has poor systolic function. As shown in the echocardiographic image in the lower right, this dog has a dilated left ventricle, a dilated left atrium, and the pump function or contractile function of the left ventricle is impaired. This can be a primary condition, again, with certain familial predispositions, such as the Doberman Pinscher or the Great Dane. But dilated cardiomyopathy can also occur secondarily. It can be diet-related, the classic example being taurine deficiency in the cat prior to the use of taurine supplementation in most feline foods. Dilated cardiomyopathy can also be arrhythmia-induced. If the heartbeat is irregular and rapid for prolonged periods of time, that can wear the cardiac muscle out, leading to dysfunction and eventual heart failure. And so we use the term of a DCM phenotype, meaning that the appearances of a dilated, poorly contracting heart, but not yet understanding exactly what the underlying cause of that may be. Secondary cardiomyopathies are disease states that result in secondary changes that can impact the heart, such as systemic hypertension, norepinephrine and epinephrine secreting tumors of the adrenal gland, systemic inflammatory response, sepsis, and other systemic inflammatory conditions. Cardiac neoplasia is becoming ever more common as our patients reach older age, as other conditions are treated appropriately. In the cat, we frequently see cardiac lymphoma affecting the muscle of the heart itself. In the dog, hemangiosarcoma remains the most common neoplastic condition that we encounter. This is a surgical case of a hemangiosarcoma affecting the right auricular appendage of a dog undergoing auriculectomy to remove that tumor. Chemodectomas, or heart-based tumors arising from chemoreceptor cells of the aorta or pulmonary trunk, also occur commonly in the dog. And mesothelioma is a disease that can affect the pleural space as well as the pericardium, leading to cavitary effusions and eventual death. Pericardial diseases themselves do occur in animals. In the dog, these are most often related to a tumor or an idiopathic pericarditis, or inflammation of the pericardium itself. In the cat, heart failure remains the #1 cause of pericardial effusion, with accumulation of fluid within the pericardial space. Infection, particularly related to feline infectious peritonitis, is another common cause in the cat. In this echocardiographic image, you can see the bright outside sac of the heart as the pericardium, shown by arrows, and the anechoic space around the heart is the effusion or fluid accumulation building up and compressing the cardiac chambers. Electrical diseases are very common, both in the setting of primary heart diseases, but also as a consequence of underlying conditions or toxicities. Congenital malformations of the valves can occur. In the AV valves, this is typically related to thickened, fused leaflets, very shortened and tethered chordae with direct papillary attachments. In the semilunar valves, these are typically fused, thickened stenotic valves, sometimes with a malformed and hypoplastic valve annulus. And in the case of the aortic valve, the more common congenital malformation is a ridge of valvular fibrous tissue just below the valve. Cardiac shunts are another common cause of congenital heart disease. We see persistence of the fetal connection between the aorta and the pulmonary trunk, which is the patent arterial duct, or PDA. We can see defects in the inner atrial septum, the connection between the two upper chambers of the heart, the left and right atrium, leading to shunting of blood from the left side to the right side and dilation of the right chambers. We can see defects in the interventricular septum, known as a ventricular septal defect. And in these conditions, shunting of blood occurs primarily in systole between the left and right ventricle, leading to a circulatory overload through the lungs and eventual congestive heart failure, or shunt reversal in the setting of pulmonary hypertension. So what we can see in this overview is that many forms of heart disease, in contrast to our understanding in the early 1900s, do occur in animals much in the same way that they occur in the human. And so small animal cardiology has made substantial advancements over the last century to both improve our understanding of the diagnostics required to both detect and stage and prognosticate animals with heart disease, and also has made substantial advancements in the therapeutics to treat animals with heart disease. So when we think about the current diagnostics that are available to the treatment of animals with heart disease, we think of electrocardiography as still the primary test to understand the rhythm disturbances that an animal may be suffering. We see this as the surface electropotentials that allow us to understand the mean electrical axis, the rate, the rhythm, and the regularity of the heart. It's electrical activity itself, manifested on the surface of the patient. We still perform thoracic radiography very commonly to understand global measures of heart size, and most importantly, to understand secondary consequences of heart disease. With congestion of the cardiac chambers, this will often manifest with left-sided heart disease as pulmonary edema and the development of interstitial infiltrates throughout the lungs, which are best detected by thoracic radiography. The mainstay of clinical practice for cardiology now is echocardiography. Cardiac ultrasound allows us to visualize the motion of the heart itself. It allows us to utilize Doppler studies to understand flow disturbances and to estimate pressure gradients within the heart. In some patients, a brief electrocardiogram in the hospital doesn't tell us the full story of their disease, and ambulatory monitoring has become useful to let us understand the frequency of electrical rhythm disturbances in the animal's home environment and over a longer period of time, sometimes up to several weeks, with newer monitors. Although less commonly performed for diagnostics, we still understand that cardiac catheterization can allow us to directly measure the pressures in the heart, which have important hemodynamic implications both for the disease and for its treatment. At the same time, we can use fluoroscopy with iodinated contrast agents or angiography to understand where these lesions occur, to visualize cardiac motion, and typically nowadays to guide intervention when we attempt to treat underlying heart disease. I'll focus a bit on echocardiography because it is the mainstay of what we currently perform for animals to understand the nature of their heart disease. And currently, echocardiography relies on two-dimensional imaging. So we're using ultrasound beams to generate a two-dimensional, real-time moving image of the heart. In this patient with a subvalvular aortic stenosis, it allows us to visualize the lesion itself, the secondary changes to the left ventricle with wall thickening and dilation, and the changes to the left atrium with dilation of that chamber as well. Utilizing color Doppler imaging, we can visualize in a separate patient stenosis of the tricuspid valve with an aliasing high velocity inflow signal that tells us that this valve is tethered, poorly opening, and has an elevated gradient during diastole between right atrium and right ventricle. Similar use of the Doppler principle can occur, and in this example here, we're using M mode with color Doppler imaging on the right and just with two-dimensional grayscale imaging on the left to visualize structures with a very high temporal resolution. It allows us to see the fine fluctuations in the aortic valve on the left and to time color events in a case of tricuspid stenosis and regurgitation on the right. Spectral Doppler imaging allows us to quantify the severity of a stenosis in the case of a subvalvular aortic stenosis on the left. And this allows us to accurately estimate pressure gradients within the heart, which have important prognostic implications for the patient as it tells us the severity of their disease. We also use echocardiography with contrast studies. In this case, agitated saline is injected into this patient's vein, and we can visualize the movement of microbubbles from right atrium to left atrium, suggesting and defining the presence of a intraatrial shunt, in this case, patency of the oval foramen. So echocardiography is used routinely for all of these imaging modalities. But the heart is not a two-dimensional structure. Rather, the heart is a complex three-dimensional shape that has unique spatial orientation. Conventional two-dimensional echocardiography is therefore limited in its ability to capture this complex geometry, particularly when that geometry is altered by pathology or adverse remodeling. And so, thinking about now, where do things move in the future? What are some recent advancements in the field of diagnostics related to echocardiography? More and more frequently, we're utilizing three-dimensional echocardiography. So rather than a single linear beam projected through the patient, we can send out a spectrum of ultrasound beams that, with the appropriate imaging interpretation, we can understand and develop three-dimensional images of the heart. This allows for multiplanar reconstruction, so three separate planes as seen in this image, as well as full volume three-dimensional capture shown in the lower right. Here's some examples of where three-dimensional echocardiography can be particularly beneficial. This is a young golden retriever who also happens to have a patent ductus arteriosus. And when we visualize the left atrium and the left ventricle and place color over the mitral valve, we can appreciate that this dog has a small jet of mitral valve insufficiency or regurgitation. And we might believe that that is functional in nature, related to the dilation that's associated with a patent ductus, which is commonly seen. When we look at the mitral valve on both the long axis and the short axis in two different orthogonal planes, we don't appreciate gross abnormal changes. Looking at this valve from an apical four-chamber projection, perhaps the anterior leaflet is a little bit tethered, but overall, this valve does not appear structurally abnormal. When we look at the regurgitation on transesophageal echocardiography, we again appreciate here the regurgitation, which is a bit more severe than was initially appreciated by the transthoracic echocardiogram. And here's the benefit of 3 dimensions. So rather than trying to acquire multiple images and understand the valve in 2 dimensions, using biplane echocardiography, we're allowed to see the normal motion of the valve, but to generate an orthogonal plane at the same time. And in so doing in this patient, we can see that the posterior leaflet is tethered. There are abnormal papillary and chordal attachments to that leaflet. And so that alters our diagnosis from a dilated left ventricle with functional mitral regurgitation related to a cardiac shunt to a concurrent defect with mitral valve dysplasia, which may have prognostic implications for this patient. 3-dimensional echocardiography also allows us to visualize the heart as we're used to seeing it, both on the surgical table or on the pathology floor. And when we're able to visualize the live beating heart with 3 dimensions, we can appreciate the normal relationships of the cardiac valves. We can better understand the coaptation of the leaflets. This is a case of tricuspid valve dysplasia, and one can appreciate on the tricuspid valve the coaptations of the leaflet is incomplete, and there's a large anatomic orifice that remains during ventricular systole in this malformed tricuspid valve. We can certainly understand that that defect is present on 2-dimensional echocardiography, but we're able to see it better and more completely with 3-dimensional echo. A further advancement recently in the use of echocardiography is the development of photorealistic imaging. So as we look at a 3-dimensional image, the computer is generating the sensation of depth by the use of color, meaning a more yellow image is closer to our eye or to the transducer, and a bluer hue to the image is further or deeper into the image or further away from the transducer. And that does allow us to appreciate depth, but that's not actually how our eye visualizes normal structures. The eye senses depth by the use of shadow and light. And so now there are methods with echocardiographic imaging to recreate these 3-dimensional images using light and shadow as the eye normally perceives it. This is a photorealistic image of a pulmonary valve in a dog. And what you'll appreciate is that I can move the light source around. It'll start on the left side of the image, and we'll drag the light source across the en-face projection of the valve, shown here, over to the right side of the image. And utilizing that light source allows us to better understand depth and appreciate anatomy the way that our eye normally sees the world around us. I can also send the light source deeper into the image and even backlight this valve to appreciate the commissural fusion that is present in this patient. So the use of photorealistic and 3-dimensional imaging has advanced our ability to make the right diagnosis in a given patient and to understand what might be complex geometry and anatomy in a way, the way our eye would typically see it on a postmortem specimen. So echocardiography has advanced over the last several decades, improving our ability to understand the heart with ultrasound. What about CT? Computed tomography was first developed in the 1970s at Atkinson Morley's Hospital in London. And Hounsfield, shown here, generated an 80 by 80 matrix by spinning or rotating an X-ray beam around a patient, and then using computed algorithms to generate a 3 or 2-dimensional image of that patient. CT technology has evolved dramatically from the 1970s, from the original electron beam CT to the use of helical CT, where now the patient can move through the beam, acquiring a more complete study over time, to the development of multiple detectors from 4 to 16 to 64 to 128. And the use of multiple detectors allows us to capture more of an organ in the z-axis at a given time. That allows us to put together three-dimensional images of a patient. The use of dual source imaging beginning in 2008 expanded our ability to freeze cardiac motion. With two sources and two sets of detectors, the rotation around the patient does not take as long to acquire a full data set, and so even fast heart rates can be visualized. 16 centimeter or 320 detector imaging, and then soon on the clinical horizon, spectral imaging, have revolutionized CT, particularly when it comes to the diagnosis of heart disease. The advantages of cardiac CT is it allows for three-dimensional volume rendering. We can view the heart from any perspective, and we can recreate image planes in any direction, also cutting in to various structures. So in these examples of cardiac CTs of patients with pulmonary valve stenosis, we can see the three-dimensional beating heart, and then we can slice through that heart and understand intracardiac anatomy in amazingly fine detail, even when patients have structural defects or rapid and irregular heart rhythms. This allows us to move beyond ultrasound, which, although still very useful, doesn't give us the full scope of the thorax and the ability to recreate any imaging plane in the way that CT does. We can also use CT to better quantify cardiac function. In this example, a dog with tricuspid valve dysplasia underwent a cardiac CT, and algorithms are performed to track the endocardial and epicardial borders of the left ventricle, shown in red and green, as well as the endocardial border of the right ventricle. And as we watch this heart contract, these algorithms can also quantify the volume of that chamber because we have three-dimensional imaging throughout the cardiac cycle, both of the right side, which is a complex three-dimensional shape, and of the left side. And you can appreciate then that in this patient with severe tricuspid valve insufficiency, the left ventricle is pumping 32 mils per heartbeat, while the right ventricle is pumping 131 milliliters per heartbeat because of all that regurgitant blood that goes back and forth across the tricuspid valve with each beat. This allows us to quantify the severity of this patient's stenosis, which really wasn't in question given the degree of remodeling, but we can actually estimate the regurgitant fraction of this tricuspid valve at 75%, which would be massive or torrential tricuspid insufficiency that will likely impact this patient's prognosis and requires therapy. Taking CT data even a step further, we can use CT to understand cardiac anatomy in greater detail. CT allows us to generate computer-aided design files or stereolithography files, allowing us to visualize the heart structures or the blood pool in very fine detail. Furthermore, it allows us to take these CAD-based files and 3D print an individual patient's anatomy from a non-invasive imaging, such as CT. Here's an example of a different dog with tricuspid valve dysplasia. And the CT data set has been segmented to highlight this patient's specific anatomy in an STL or stereolithography file. That allows us to spin the heart around, understand its three-dimensional appearance, but not just on a computer screen. It allows us to actually generate models of this patient's heart that we can then visualize, hold in our hands, use as a model to practice a surgical approach or to implant a device and test a novel intervention. So CT both improves our diagnostics, but also helps us better plan for intervention. We can visualize any cardiac defect by CT. On the left is a still rotating image of a patient with pulmonary valve stenosis. And we can appreciate all the fine trabeculations of the right ventricle and the narrowing of the pulmonary valve annulus with post-stenotic dilation of the pulmonary trunk and left branch pulmonary artery. As a cross-sectional short-axis image, we can appreciate a ventricular septal defect through the muscular septum in this dog that also has concurrent pulmonary valve stenosis. Less common defects can be visualized as well. In the image on the right, we see a fibrous obstruction in the middle of this dog's right ventricle. The pulmonary valve is normal, but the proximal right ventricle is hypertrophied, and the mid-valve or the mid-right ventricular obstruction is the condition known as a double-chambered right ventricle. When we're considering intervening, in this case in a dog with pulmonary valve stenosis, the use of CT also allows us to make very precise measurements in any plane. So rather than hoping that our two-dimensional echocardiographic image is sagittal and optimizing the diameter of a given valve to size a balloon, with CT, we no longer have a question about whether we're in the right plane and whether we're central to the valve to create an accurate sagittal measurement. So the measurements by cardiac CT become more reliable and can be performed in any plane. CT also allows us to see structures that we cannot visualize well by echocardiography. Echocardiography has outstanding temporal resolution, but not as good spatial resolution. The ability to see very small structures with echo can be challenging in some cases, particularly as those structures extend outside of the imaging windows provided by the cardiac notch. The newest forms of cardiac CT allow the freezing of cardiac motion with very rapid temporal resolution, and also have outstanding spatial resolution, which allows us to visualize the coronary arteries themselves. Certainly, this has been driven by the human field, where coronary arterial disease is a major morbidity. But it is also important in the animal population, particularly in patients where we might intervene on their pulmonary valve, as we do see patients that have coronary anomalies that could be damaged if we were to intervene in the pulmonary position. So just as a reminder, the normal coronary artery anatomy of the dog involves two major vessels that arise from the aortic root, from the left adjacent sinus and the right adjacent sinus. The right coronary artery extends out of the right adjacent sinus just to the right of the pulmonary outflow tract and encircles the tricuspid annulus in the right AV groove. The left coronary artery is a short branch in the dog, which quickly trifurcates into the circumflex, which wraps around the left AV annulus to descend into the subsinuosal at the posterior or caudal aspect of the heart. And the periconal divides the interventricular septum, interventricular groove between the right and left ventricles. Again, the subsinuosal artery descends along the caudal aspect of the heart as a branch of the circumflex. So we can appreciate this anatomy certainly on the postmortem specimen, but now with cardiac CT, we can understand this anatomy in the living patient as well. So in this example of a cardiac CT performed at the aortic root, we can see the right coronary artery leaving and heading straight ventral towards the sternum of this patient. And we can also see the origin of the left coronary artery, as well as its divisions into a septal, periconal, and circumflex branch. In a still image from a three-dimensional volume rendered CT, we can spin the patient's heart around, visualize the pulmonary outflow tract and its relationship to the coronary vessels, understand the perforating vessels and the obtuse marginal branches of the circumflex and periconal arteries. We can understand the septal branch that descends along the interventricular septum, and we can visualize the subsinuosal artery at the caudal or posterior aspect of the heart as it descends to perfuse the caudal wall of the left ventricle. So again, with CT now, we can appreciate the small coronary arterial anatomy that would not have been apparent by echocardiography. And this is why it becomes important. Here's an example of a dog with pulmonary valve stenosis in which we might want to intervene and try and open up this pulmonary valve, either by surgical operation or by interventional catheterization. When we look at the same patient's left heart studies, we can appreciate that in this dog, there is a single origin of the coronary vessels from the left sinus, from the right sinus, and that the left coronary artery arises from the right sinus and takes a course in front of the pulmonary valve, encircling the pulmonary valve, which if we were to inflate a balloon or if we were to perform an operation and transect the outflow tract across the stenotic valve, we would damage and or lacerate that coronary vessel, which would be fatal for the patient. Seen in a dorsal projection, you can see that the coronary vessels arise from the right sinus here, and the normal course of the right coronary artery can be seen, but the left coronary artery arises out of that same sinus and is taking a course cranially around the pulmonary valve, seen here, limiting our ability to intervene in that patient. This is a different dog with a different coronary anomaly, but the same unfortunate result for the patient. We can see that this dog has a single left coronary artery and that the right coronary course takes a pre-pulmonary course around the pulmonary valve to get over to the right side of the heart. Again, if we were to intervene and dilate this valve, we might impinge or potentially damage that coronary vessel. And if we were to perform a right ventriculotomy and try and open up this outflow tract surgically, we would transect that coronary vessel. So cardiac CT has made substantial advancements in our ability to understand cardiac anatomy and to visualize the heart. Less advanced, but still as useful, less advanced in the sense that it's less well developed in animals, is cardiac MRI. So with the use of radiofrequency pulses and a strong electromagnetic field, images of the heart can be obtained with very good spatial and temporal resolution. The additional benefits of cardiac MRI, similar to CT in its ability to visualize three-dimensional anatomy, MRI also allows for more tissue characterization. Utilizing T1 or T2 maps allows us to understand what's going on in the myocardium itself. In this patient with right ventricular hypertrophy, the T2 map shows a heterogeneous appearance to the of the right ventricle, and the delayed gadolinium enhancement image on the far right shows a lighter appearance to the right ventricle. Both of these suggest interstitial fibrosis and pathologic changes to the right ventricle in this dog. So the MRI allows us to visualize structural changes, but also better appropriately characterize tissue changes as well. Just as an example of the structural abnormalities that can be visualized by cardiac MRI, this is a patient with a pulmonary valve stenosis and a patent oval foramen. And we can appreciate in this dog that the interatrial septum is not closed. We can see the valve of the fossa shown here, or septum primum, and we can see the communication between right atrium and left atrium related to that structural defect. You can appreciate that we can see the mitral valve, we can see the tricuspid valve, and even the chordal attachments of that valve in fine detail with cardiac MR. Now we see that this valve looks like it creates an opening, but in addition, with real-time gadolinium perfusion, we can appreciate that that opening is patent. As the gadolinium comes into the right side of the heart, it immediately fills over in the left atrium before we see circulation through the lungs, suggesting that this flow in the atrial septum is from right to left, related to patency of the oval foramen. So those are some advancements that we've seen in diagnostics, both the increasing utility of echocardiography, the use of three-dimensional echocardiography, and the development of cross-sectional imaging, including CT and MRI. What about advancements in how we treat heart disease? There are three mainstays for the treatment of patients that have heart disease, be they human or dog or cat. And those are medications, pharmacologic therapies, surgical therapies, which may be closed heart or open heart, requiring cardiopulmonary bypass as shown here, or interventional therapies. Interventional therapies meaning minimally invasive image-guided therapies where we advance catheters, devices into the heart, guided by fluoroscopy or ultrasound or some imaging modality to effect a therapy. In this case, stenting of the pulmonary valve. If we look at some advancements that have been made in each of these areas, we'll focus primarily on intervention as it's my major clinical focus. But a few comments. Prior to the 1990s, we really had no randomized controlled clinical trials in veterinary medicine. Since that time, dozens of trials have been performed, which allow us to finally take a scientific approach to the treatment of heart disease in dogs and cats. Rather than expert opinion, which is a fairly low grade of evidence, we now can look to trials that were randomized, that had a placebo control, that were blinded both to the investigator and to the client that owns that dog. And that allows us to understand which of these therapies has a real and measurable impact in the treatment of heart disease. And this has led to expanded indications for some medications, and it has led us to stop giving medications in some situations as the trials failed to show benefit. From these clinical trials, we also now have consensus guidelines for the management of heart disease in the dog and the cat, at least for the major and most common conditions that those species suffer. So medical therapy has evolved over the last several decades by a more scientific approach to treatment and by convening of expert consensus panels to interpret those scientific studies. There have been many surgical advances as well. That's not a focus of mine, and in the interest of time, I'm going to spend the rest of the morning, or for you, the evening, focusing on what advancements we've made in the area of cardiac intervention. So the ductus arteriosus, or the arterial duct that is present in the fetus, should close at the time of, shortly after the time of birth. But unfortunately, in some patients, we see this communication from aorta and pulmonary to pulmonary artery persist. In the postmortem specimen on the right, you can appreciate the aorta coming at you, and this is the ductus arteriosus connecting from the aorta into the pulmonary trunk itself. And again, with three-dimensional echocardiographic imaging, we can see the aorta, and we can see the opening of the ductus and the entrance into the pulmonary trunk. Angiographically, we can appreciate this as well, either by conventional angiography in the descending aorta or by CT angiography, cardiac CT shown on the right. In both of these imaging modalities, we can appreciate the connection between the aorta and the pulmonary trunk as the patent ductus arteriosus. This leads to shunting of blood from the aorta to the pulmonary circulation and back to the left side of the heart. That will lead to progressive left-sided heart enlargement, eventual congestive heart failure, or the development of pulmonary hypertension, which may cause shunt reversal. Surgical options for many years were the main way to treat this, but we now have less invasive options for our patients that we can use to close this fetal communication. Rather than opening the dog's chest, retracting the lungs, and carefully dissecting around the ductus, now we instead come into the femoral artery in a less invasive approach and advance a catheter into the femoral artery up to the level of the ductus, crossing the PDA itself and into the pulmonary trunk. We now have devices that are specifically designed to close the communication that is present. And so this is a nitinol self-expanding device, and we will advance the device into the pulmonary trunk, retract the disc on the pulmonary side up against the ostium of the ductus arteriosus, and then expand a second disc, which will open in the aortic side of the ductus. These two discs create a clamshell-like effect that will come together and lead to occlusion of this vascular communication between aorta and pulmonary artery. We still have control of the device. We can push and pull on that device and make sure that that device is securely positioned. We can perform angiography and confirm that that communication between the aorta and the pulmonary artery is now completely closed. And once we're happy with the positioning and the outcome, we can release that device just by counterclockwise rotation of the cable that attaches to the disc itself. That remains in the patient, and the PDA is closed. So rather than recovering from a thoracotomy, the patient simply recovers from arterial access into the femoral artery, which is minimally invasive and can lead to discharge the same day or the next day if necessary. Postoperatively, you can see the device is visualized on thoracic radiographs. We can also see it by cardiac ultrasound, and we no longer see a connection between the aorta, shown in the far field, and the pulmonary trunk, shown in the near field, and the PDA is occluded here with the device. This is now routine and the common approach for the treatment of PDA in the dog. We can also treat PDA in the cat. Here's an example of a 2-year-old domestic shorthair that had a murmur noted 1 year ago. A surgical approach had been performed at a referral practice, but when the surgeon entered the thorax, they failed to find a PDA. They therefore performed a cardiac CT and reached out to our center for catheterization. When he arrived at our center, this cat had a 5 out of 6 left basilar continuous heart murmur. The heart rate and rhythm were regular. He was tachypnic, the lungs were clear, and the femoral pulse was dynamic. We reviewed the cardiac CT that had been performed at the other center, and in this case, we were able to visualize that there was, in fact, a ductus between aorta and pulmonary trunk, but that it lies, in this case, quite medial. So 3-dimensional reconstructions of this patient's anatomy allow us to better appreciate here the ductus from descending aorta into pulmonary trunk, and shown here as well. So perhaps not terribly surprising, it couldn't be visualized by the surgeon. It lies on the medial aspect of the aorta in this case. And so as we outline these structures, you can see that the prior thoracotomy failed to visualize this defect because of its medial location. That does potentially pose some challenges from a surgical perspective now. We would be reoperating into an incision that has already been operated. And even then, there would still be the chances that we would have trouble visualizing this anatomy. This is, again, where the benefit of intervention can come in handy. So in this case, we accessed this cat's external jugular vein percutaneously. We advanced a catheter into his heart, performed an angiogram, which allows us to visualize the pulmonary trunk and the dilated branch pulmonary vessels. We can see that his aortic root is dilated as well. And on the levo phase circulation back from the lungs into the left heart, we can see the ductus, which lies right here. We advanced a catheter out the pulmonary artery, and then over that catheter over that guide wire advanced a catheter that we could position in the pulmonary trunk and utilize that catheter to probe the opening of the PDA. The fact that it's medial has no bearing on our ability to catheterize this interventionally, because we're simply using the wire to find this ostium as it lies within the patient, guided by the fluoroscopic imaging. So once we cross the PDA retrograde with our microwire, we then advance the catheter over that wire into the descending aorta, and now we have retrograde access across this PDA. We can perform an angiogram now in the aorta, and we can visualize the PDA more clearly than we saw it on the levo phase from the right heart injection. And we can deploy a coil, which in this case, we will position on the aortic side with several coils. This is an occlusive coil that has Dacron fibers that will lead to thrombosis. We pull that back into the ductus itself, and then we position 1 to 2 loops on the pulmonary arterial side so that this thrombogenic coil crosses the ostium of the PDA and now is tightly positioned on the aortic and the pulmonary sides. This is also a device that can be released by rotation. And as we release the device, we see that it holds its position appropriately within the ductus and in this case, the PDA was completely occluded. So now the device is released, the catheter and the wire comes out of the cat's jugular vein, and it's as if he simply had a blood draw out of the jugular vein, and no further incision or recovery is necessary. Thoracic radiographs document the position of the device the next day, and echocardiographically, we see that there is no flow into this PDA, and we can visualize the echogenic coil as it enters into the pulmonary trunk. Just as a slight deviation from talking about dogs and cats alone, these tools can be used for any species. Obviously, they're used routinely in humans. We now use them routinely in dogs and cats. This was an interesting case from a few months ago of a patient that has a PDA. Obviously, the anatomy here likely looks a bit odd, but similar to that cat approach that I just showed you, we've come down the jugular vein into the right heart, out the pulmonary trunk, and then crossed a PDA into the descending aorta. This is the descending aorta here. This is the PDA as it enters into the pulmonary trunk. This was a patient that was having exercise intolerance, cyanosis, and difficulty breathing. To close this PDA, we used a slightly different device. This is a Amplatz vascular plug, which is used to close vascular communications throughout the body. It is also delivered through a catheter. In this case, a very low-profile device, which allows us to deliver it through just a 5 French catheter. It's a self-expanding plug, which will close off this communication, the ductus, in this patient, and similarly can be released with counterclockwise rotation on the wire in the delivery cable. And now that PDA is closed. This patient is Blue, who is a pet chicken that we recently treated. So again, these devices and techniques are of benefit to dogs, cats, but any species with a heart condition can be treated in this way. Moving away from the PDA, we'll consider the stenotic pulmonary valve. Dealing with patients that have pulmonary valve stenosis can be challenging. Here on transesophageal echocardiography, you can see that the leaflets of this pulmonary valve are stuck together, and that leads to poor blood flow out the right side of the heart, a compensatory hypertrophy of the right ventricle, and eventual right-sided congestive heart failure. This patient was having syncopal signs, was collapsing, and was exercise intolerant. We again entered the jugular vein. We perform an angiogram, and we can visualize these leaflets of the pulmonary valve seen here as stenotic fused leaflets. We can size the diameter of this pulmonary valve annulus, and we can advance a balloon dilation catheter across that pulmonary valve. As we rapidly inflate that balloon, you can appreciate initially that there is a small waist or indentation where those leaflets are fused together. But as pressure generates within the balloon, that radial force tears apart those leaflets, opening up the pulmonary valve. Immediately afterwards, we can see much better excursion of these pulmonary valve leaflets. The tips are no longer fused together, blood flow is improved, and the pressure in the right ventricle immediately falls. Angiographically, we can see that flow through the pulmonary valve is much better, and this patient's clinical signs resolved completely. What about patients whose valve is so malformed and thickened that a balloon dilation is ineffective? We now have therapies to treat this as well. This is a 14-week French bulldog who has a heart murmur. He's smaller than his littermates, and he tires very easily. The referring cardiologist diagnosed severe pulmonary valve stenosis, right to left shunting of blood through the patent oval foramen, and commented that a balloon valvuloplasty, given the severity of this patient's disease, would be unlikely to have success. Because of the right to left shunt in this dog, erythrocytosis was present, the dog was hypoxemic, and the hematocrit or packed cell volume was 69% at presentation. On the echocardiogram, you can appreciate the severity of the right ventricular hypertrophy seen here, severe dilation of the right atrial chamber, flattening of the interventricular septum, suggesting pressure overload of the right side of the heart, And the visualization of the pulmonary valve was challenging. There's clearly stenotic blood flow with aliasing color Dopplers showing through that region, but difficult to actually see valve structures in clear detail. Transesophageal echo was a little bit better, but again, we see a severe tight stenosis throughout a segmental portion of the pulmonary trunk, suggesting that just a balloon dilation will be ineffective for this patient. We did perform cardiac CT, both to understand the coronary anatomy, because this is a bulldog and at risk for coronary anomalies, but also to better understand the anatomy of the pulmonary valve itself, given that this is such a malformed valve. In this patient, you can see severe fibrous adhesions on the two-dimensional image. There's some artifact related to an irregular heart rate, but we can appreciate the dilation of the pulmonary trunk, the dilation of the sinuses, and the severe obstruction shown as a filling defect in the three-dimensional image and shown as fibrous tissue with adherence to the pulmonary leaflets themselves on the two-dimensional image. Looking at this dog's coronary arterial anatomy, we can appreciate the aortic root in the center, dilated right atrium here. Pulmonary outflow tract is seen right here with branch pulmonary arteries to the right and the left, seen here. And again, we see this thickened, fused, abnormally formed stenotic valve. We can appreciate that the coronary vessels themselves are actually appropriate or normal, with a right coronary artery and a left coronary artery out of their respective sinuses. In the dorsal reconstruction, we can see the severity of the right ventricular hypertrophy and the severity of the right atrial dilation. We can appreciate, again, the pulmonary valve stenosis that is present right here. So severe dysplasia and stenosis of this pulmonary valve. We took this dog to the cath lab and we performed a right ventricular angiogram. You can see the severity of this stenosis correlates with both the CT and the transesophageal echo findings. There's just a pinhole opening between the valve sinuses and the pulmonary trunk itself. And the severity of this lesion, again, was not thought to be amenable to balloon dilation. Again, this is a dog that has severe clinical signs, was hypoxemic, had an elevated red blood cell count. And so we just felt that the benefit from a balloon would be uncertain. We advanced a sheath into the pulmonary trunk across that stenotic lesion. We prefer to advance a stent within a sheath so that the stent is not entangled in chordae of the tricuspid apparatus, nor can the stent dislodge as it traverses through the thick hypertrophied right ventricle. Once the stent or the sheath is in position, we advance the stent, which is placed around a balloon catheter, and then we will position the stent across the stenotic pulmonary valve, perform an angiogram to confirm our positioning is appropriate. And what you can see on this injection is when we inject into the right ventricle of this dog, we don't see any blood flow leaving the right side of the heart. The stenosis was so severe that just the stent crossing the valve led to a complete obstruction of the outflow tract. The patient was unstable, not surprisingly at this point, and so once we were confirmed we were in the correct position, we deployed the stent. The benefit of a stent here is rather than a balloon which will be deflated and removed from the patient, we can physically hold open the outflow tract with the metallic stent once it is expanded into the outflow tract of this patient. And now with the stent implanted, we can see on repeat angiography that blood flow out to the lungs is dramatically improved. By transesophageal echo, we can see the positioning of the stent, and we can now see laminar blood flow of low velocity across that stenotic valve. With photorealistic imaging, we can look down the barrel of that stent. So the stent is here, and we can see that we now have a patent outflow tract and a wide opening. And then with Doppler, we can appreciate that the pressure gradient now across that valve, which once exceeded 100 millimeters of mercury, is now only 11 millimeters of mercury. These are the films post-operatively in this patient, and this is the same dog 1 month later. And we can appreciate that a dog that previously was not able to do anything and tired rapidly, had frequent syncopal events, is now able to play and have a normal quality of life and normal activity level. His hematocrit is also stabilized now at 57% 3 months post-stenting. What if we actually wanted to replace the pulmonary valve in its entirety? This is now where human medicine has advanced to. So we're able, in this case of a human patient given to me by an MD colleague, a previously operated tetralogy patient with a stenotic and regurgitant conduit in the right ventricular outflow tract. Rather than reoperating this teenager, this patient's pulmonary valve was completely replaced through the femoral vein using a Melody valve. The Melody valve has a platinum iridium stent frame and then a bovine jugular vein sewn into the inside of that. And so what was once the stenotic valve now becomes a completely competent and replaced pulmonary valve. So moving now to the major issues we deal with in the dog, valve disease, be it congenital in a rare number of cases or very commonly degenerative in nature. We know that since the 1960s, valves can be replaced in the heart of the human. And there's documentation in the animal that this can be done as well. George Eister in 1976 published a Starr-Edwards valve implanted into the mitral position of a dog. Unfortunately, the surgical risk of a surgical valve replacement remains high for animals. So too in humans, sometimes the surgical risk is prohibitive, and they have enough of an understanding of comorbidities that they can predict the mortality rate of a patient based on their underlying conditions and diagnostic findings. And for some patients, it is evident that the risk of a replacement of their mitral valve, aortic valve, pulmonary valve is of undue surgical risk. And there is a need to be able to replace these valves without cardiopulmonary bypass and a major operation. This then is the advent of transcatheter valve therapies. The notion here is that the valve, as we saw in the pulmonary position, so too in the aortic position, can be replaced by catheterization alone. In the case of calcific aortic stenosis in the human, a major disease in the aging population of the humans, we see that many of these patients have severe underlying diseases that would preclude the ability to operate their valve surgically. Instead, a novel new valve can be implanted through the aortic access from the femoral artery over a guide wire. The valve can be positioned with fluoroscopic imaging across the diseased valve. It can be rapidly expanded, typically in the setting of tachycardic pacing to limit cardiac output during expansion of that valve. And that valve can plasty the diseased valve to the side with a neo valve within that stent frame that will completely resolve this patient's aortic stenosis in a minimally invasive way. With the implantation of that transcatheter aortic valve, now the patient can, in theory, go home within a day or two rather than multiple weeks of hospital stay or high risk of morbidity or mortality had it been a surgical operation. This was first performed by Alain Cribier on April 16th in 2002 in France, in Rouen, in a 57-year-old man with severe aortic stenosis. Since then, over 100,000 transcatheter aortic valves have been implanted in the human, and the growth market of that is substantial. So the question is, can we do the same in a canine patient? And the answer to that is yes. This is Sabbath. He's a 7-year-old Malamute who unfortunately had infectious endocarditis of his aortic valve. In this dog's aortic valve, we see thickened leaflets and severe insufficiency on transesophageal echocardiography. The valve was both stenotic and insufficient, and the dog was in left-sided congestive heart failure on high doses of diuretics, which had led to renal dysfunction. Because he's a Malamute and 50 kilograms, the size of his aortic root was thought to be appropriate for a human device. And we took him to the cath lab with the help of our local MD colleagues. And you can see in his aortogram that the left ventricle, shown here, fills rapidly because this aortic valve is almost completely insufficient. There is some forward flow, but there's severe marked aortic insufficiency and regurgitation across that valve, which is why his heart has enlarged to the extent that it has, and why he was in refractory congestive heart failure. The device was advanced from his femoral artery in the descending aorta, positioned at the level of the aortic root, and then rapidly expanded under tachycardic pacing. And we can see that with implantation of that valve, the post-operative or the post-implantation angiogram now shows a completely competent aortic valve with no insufficiency, normal coronary circulation, and this dog was completely taken off of diuretic therapy and remains alive 2 years later. This is his valve on transesophageal echo after implantation, and you can see the neo valve leaflets are nice and thin. The flow is laminar, there is no stenosis, and there is no insufficiency across this valve. The post-operative films show the valve in the aortic position. And this is the dog. The large one in the middle is Sabbath. This is him 1 year after transcatheter aortic valve replacement with a normal energy level and not requiring any cardiac medications. So it does seem feasible that transcatheter aortic valve replacement is possible in the dog. Unfortunately, aortic valve disease is not the primary disease that we see of the valves of the dog. And the aortic valve, being a cylindrical appearing valve, lends itself rather well to implantation of a cylindrical stent with a neo valve inside. The mitral valve, which is the #1 disease that we see in the dog, degenerative mitral valve disease leading to mitral regurgitation and congestive heart failure, is unfortunately a much more advanced condition and a much more complex geometry. So if the road to transcatheter aortic valve replacement looks like this, the road to transcatheter mitral valve replacement looks like this. With that said, there are several devices in development. We have a few at Colorado State that we have successfully implanted in dogs. And we believe the future of valve therapy for the dog will be catheter-based interventions to either repair or replace the mitral valve prior to the onset of congestive heart failure, just as it is now becoming the standard of care in the human. So where is veterinary cardiology in 2021? I think that's too broad of a question for myself to answer, but in my own opinion, I think the stethoscope still remains the primary diagnostic tool to detect the presence of heart disease. For all of these cases that you've seen, the diagnosis was made because a veterinarian listened carefully to an animal's heart, heard a heart murmur, heard an irregular sound, and referred it for further imaging with echocardiography, CT, or otherwise. So the stethoscope remains the principal diagnostic tool by which we can understand heart disease could be present. And that leads us to further diagnostics and imaging. I think the advancements of cardiac imaging over the last several decades are enormous. And in my opinion, cross-sectional imaging is a real advancement, particularly with cardiac CT, that allows us to understand the anatomy of our patients in their beating heart to better plan interventions. I think we need to consider a tripartite approach to therapy. Therapy for heart disease is both medical, hopefully based on rational scientific principles from randomized controlled clinical trials. Therapy remains surgical for many conditions where there are no good medical options or there are no interventional therapies. But for those therapies that have an interventional option, I think the ability to treat heart disease in a minimally invasive manner is to the benefit of the patient. And I think these minimally invasive therapies are both here in the setting of many congenital heart defects with closure of PDA, opening of stenotic valves, and are soon on the horizon for more advanced therapies to actually replace or repair diseased aortic, mitral, tricuspid, or pulmonary valves. Obviously, a lot of the images I've shown you require a large team of amazing people, and those listed here are just some of the many that have helped us make some of these advancements here at Colorado State over the last several years. And with that, I'm happy to answer any questions that you may have.
Not much questions for this presentation. Dr. Brian, this was a mind-boggling presentation what you made. Unimaginable. We could never imagine that these things are happening in the veterinary world. Today morning, we brought a medical interventional cardiologist to our hospital, and I said that these are the procedures the guys are doing in Colorado State. He was so astonished. Possibly he would be among the audience. He took the link today. Probably he would have been listening to you. This is mind-boggling work. Keep continuing and rise to the highest levels of care. Probably your therapy should translate into human medicine.
Well, thank you so much for your kind comments. That is the goal. I consider heart disease to be agnostic of species. I think what we learn from the dog can help the human, and what they learn in the human can help the dog, and it works both ways.
Thank you so much. In the future, if ever any opportunity arises, we'll be looking for your help.
I would love to help if I can, and I'm sorry I couldn't be there. I'd love to visit someday. I'd love to see your country.
All right. Thank you. Have a good day.
Thank you so much.